Hi, and thank you for joining us right here at Prostate Cancer Live. My name is Todd Hartley, and I'm joined by Rich Bevan-Thomas at a USMD in Arlington, Texas. That's the Dallas-Fort Worth area. Doc BT, good to see you.
Hey, good to see you, Todd. It's good to see you're back, and we're back in action doing these talks for people.
Our audience continues to grow. I think we're somewhere around 90,000 followers right here on Google+. And I think it's a real sign that people appreciate the information and the fact that you're doing this regularly. So thank you very much.
Yeah, and I appreciate it, Todd, for, again, inviting me and letting me help out with that. And I think it's been a great experience. I've actually had several of my patients that have actually gone on to this on a regular basis. And so, again, any patients that are out there that listen to this, whether it's going to be live or whether it's in the future, send us some feedback. And, we're more than interested in taking topics from people. And hopefully, again, my primary goal, as you've discussed multiple times, is to educate the patients. And we're going to bring that down a level so everybody understands, some of the intricacies of prostate cancer, which can be pretty complex.
Doc BT, it's interesting. We are consistent with this same type of answering questions for patients in breast cancer, and that campaign is at about 700,000 followers. It's about 18 months older than what we've created here with you at Prostate Cancer Live. And I know you just went out to AUA and you provided a lot of information at the biggest conference of the year, and you brought that back to patients so they could understand what's developing in prostate cancer treatment. And any of you in the audience that would like to go back, please do. It's great information that Doc BT provided. Now, there's a lot of PSAs out there. Today we're going to try to boil it down, make sense of it. So, Doc BT, can you tell us about the different PSAs, and isn't there a new PSA that's out? To give us the lowdown on that.
So yeah, Todd, and this was kind of a hot topic at the AUA. We actually gave our webinar that we did in our chat was actually on Saturday, and a lot of the buzz was about this PHI test, and it's called the Prostate Health Index. But I think in order to understand that test, we really have to go back and we really have to look at all the aspects of the PSA. All right, so let's go down memory lane. Now, we've done this before in several of the talks. So the PSA, again, it's a molecule, okay? It's an antigen, which is a protein, okay? And it's produced by the prostate. Okay, now, the goal of that PSA, okay, is when a man ejaculates, it's actually in the semen, and that actually helps break down, the protein molecules, so basically that the sperm can survive for, upwards of 36 hours, right? So that's the PSA. So that molecule, and again, you remember my broken egg routine, which is the fact of, if you look at, or the leaky pipe, is that the prostate's a bit of a leaky pipe, right? So a small amount of that molecule, that protein, will be leaking out into the bloodstream. And that's okay if it's a small amount, right? So, but if it leaks out at a higher amount, then there could be something else wrong with the prostate, okay? So again, that leaky pipe, that protein that's produced by those prostate cells, not just prostate cancer cells, but by prostate cells, okay? That's the PSA. Prostate-specific antigen. Okay, again, developed, originally in the 80s. We started getting, approval for it late 80s, early 90s, and we've used it. And we've actually seen by utilizing the PSA, we've actually decreased the mortality, the death rate of prostate cancer, upwards of at least 20 to 40%, whether you look at, the United States or several other European trials on this. So at the end of the day, it's still a great test, but it's got its limitations. So what's happened, and this has been going on for a number of years, but what's happened is we've been looking at, that PSA and how do we crack open that nut a little bit better, so we have all these what's called isomers of this PSA. So this is a molecule, it's a protein, and so we look at that in terms of the components of this PSA. So let's start off and talk about the total PSA. So patients will ask me this, and they're astute, and they say, why do you call it the total PSA? And we call it the total PSA because it has components of that, right? And so one of the early things that we've known about the PSA is that you could actually, of that total PSA, of that number, again, whether you're the number of, maybe 2.1 or maybe it's 5, whatever that is, that number is composed of free PSA and complex PSA, right? So total, we're going to break that down. We got free and complex PSA. So we've been using the free and the complex PSA for actually quite some time. And one of the best things that we've been using that for is for patients with a negative biopsy Okay, so they've had a negative biopsy. We see them back in the next year or 2 years and their PSA is still elevated. We will then look at that percent-free PSA. And with a percent-free PSA, it's the exact opposite of the total PSA. Okay, so now, I've got, as that total PSA rises up, think about that leaky pipe, right? So that leaky pipe is leaking out some of that PSA and it's going into the bloodstream. The higher the amount of that PSA that's actually going into the bloodstream, higher risk there could be a focus of cancer. Again, we've had this discussion before. It's not always just prostate cancer. It can be an infection. It could be inflammation. It could be just the size of the prostate. So there's other factors that can be involved in there. But again, higher the PSA, higher risk there could be a focus of cancer. Now, let's unpackage that total PSA and let's look at that percent-free and the complex, right? So instead of us actually, looking at both of those, routinely we report it as the percent-free. And the percent-free is that component of that PSA which is not actually combined with another protein. All right, so what we'll do is we'll get a percent-free. So for instance, a patient will have, for instance, a PSA of 4.2, and he'll come into the office and we'll get a total and free PSA. His total PSA is 4.2. We'll get a percent-free of, let's make it up, 25%. Okay, now, with the higher the percent-free PSA, i.e. anything above, 25 or 30%, the better chance that that patient actually does not have a focus of cancer. Let's look at it the other way. Higher the total PSA, the lower the percent-free PSA. So it's the exact opposite. As that percent-free PSA goes down, the higher risk that they could be harboring a focus of cancer. And Dr. Catalona actually did a lot of these studies on these, great studies on here. So really what we're looking at, and there's no real true cutoff, but I mean, we start getting really nervous once we start seeing that percent-free PSA below 15%, below 12%, and certainly below 10%. So if that same man walks into my office and his PSA was 4.2, and instead of his percent-free PSA of 25%, it comes back as 10%, that's a guy that I'm worried that he could be harboring a focus of cancer. Okay? Make sense? So that's pretty easy because we're just looking at one number, right? And it's important to understand these things because we're going to be using all of these things in what's called the phi test. All right, so that's part one. Part two is we're looking at the isomers, which are basically just the compounds of that PSA. We have another one called the pro-PSA, right? And the pro-PSA, and again, is another factor inside of that PSA, which again helps us figure out whether there could be a potential risk of, again, that pro-PSA. Right, so again, another factor in that. Yeah, go ahead.
I want to make sure I'm following. So there's a free and complex PSA, and that's the more traditional test that you've been giving over the years. Is that right?
Exactly. Yep.
And now there's a phi test, and this is the new test that is rolled out onto the scene, and that looks at pro PSA?
It does. So let me get to that. So you're a fast thinker, right? So here's what we got. We've got percent-free PSA. We got the pro PSA. And again, the pro PSA we've used, which is actually, again, a component of this. But now we're going to put all of those together. And now what we get is we get a formula, right? And that formula actually looks at the pro PSA and the percent-free PSA. So go ahead and put that formula up for the audience on the screen, if you would.
All right, let me do that. And there we go. You let me know when you can see it.
Oh, that's the first. That's the second one. Give me the first one.
All right, excuse me.
Okay, so here's the one. So let's take a look at this. I'm going to talk over this image real quick. So the phi, again, which stands for Prostate Health Index, is a blood test. And that blood test looks at the pro PSA divided by the percent-free PSA. All right, so the higher the pro PSA, which again that's that P2, it's the 2 isomer of the pro PSA, but that's the pro PSA. The higher that test is, higher risk of cancer. Okay, the lower the percent-free PSA, higher risk of cancer, and that's times the square root of the total PSA, right? Okay, so I don't want everybody to get confused. As Chevy Chase says, I was told there would be no math. So let's flip that thing out, Todd, and let's get back to chatting a little bit about this, right?
Oh, okay.
So we're going to go to the next one in just a second. Okay, so now we got lots of formulas and everything's crazy going on and everybody's got a headache, right? So let's just look at the basics of this. Why am I telling people about this? It's important because the phi test, phi, P-H-I, stands for Prostate Health Index. It is exactly that formula, right? So when we draw a patient's blood, and it's a new test, right? So when we draw a patient's blood now, we're actually getting all of these components of that. We're going to get the total PSA, we're going to get the percent free, and we're going to get the pro PSA. And then it goes into this formula that lets us know what, basically what number we're going to get. So those patients are going to get a formula and that number, which is going to be the phi number. Okay? All right, now let's go to that second picture, which explains what that number is, right? Second picture coming up. Good work. Okay, so now let's take a look at this. Okay, so I'm going to kind of go over the screen here real quick. On the top upwards point there, we're seeing what's called the Beckman-Coulter, and that's the name of the company that actually invented this test. And there it's called the phi range. So again, just similar to the ranges that we talked about on the percent free PSA, we also have the ranges for phi, right? So if it's a low prostate health index, a low phi, the probability of that cancer is you kind of just scroll over. So we got 0 to 26.9, which is a relatively low. The probability of cancer is actually low. It's about 9.8%. It still exists. We can't have any zeros, unfortunately, but it's 9.8%. And the confidence interval is, it's about 5 to 15%. It's a 95% confidence interval. So in other words, there's a very high chance that there's a confidence interval on that. Okay, so then we go to 27 to 35. Once you hit that 27 threshold, you start seeing a higher risk that there could be a focus of cancer. So if we work our way over 27 to 35, now they've got a 16.8% chance, right? And again, the confidence interval is still very, very good there. And then as you go up higher, that 36, then you get a 33% chance of cancer. And again, if your phi score is 55, you've got a 50% chance of cancer. Got it? Okay. Got it. So let's flip back. Let's talk to us now. So why is this important? Well, one of the challenges that we've had, and the PSA gets a bad rap, I mean, it's sort of like, it's a great test, but we've got to use it, and we've got to figure out the best utility for this test. So anytime we can use any of these isomers for this test, which is exactly what this is, it's using all of those components together, and it's put into this formula, right? So we got this formula, and the question is, how do you use that? Well, it's a relatively new formula, and the data is coming out over the last couple of years, but it's been it's becoming much more of a hot topic. Right now, as they're rolling out this test, again, because they figure out this formula, it's getting I think it's getting sent to Virginia, I think. And in the fall, we're going to be one of the clinics at USMD. We're going to be one of the clinics that actually is able to offer it to our patients. But, several clinics should be able to run this, but they're going to have to send it off to Virginia, and then they'll get the report back a week later, right? And the reason why is because they want to make sure that you're getting a good, you've got to get, it's garbage in and garbage out. We've talked about that before. You've got to make sure that we're getting those good, you're measuring those isomers legitimately, so you're coming out with the right score. Because as that phi test increases, it tells us two things. Number one is that there's a higher risk for those patients having prostate cancer, right? But number two is there's a higher risk of those patients having a more aggressive type of cancer, right? Okay.
Now, how many locations did you say that they're going to be rolling this test out? There's only a few, right?
Yeah. So I mean, it's going to be several. In the fall. The problem is I think that from this test wise, it's about quality control, and they need to make sure that they actually have all the quality in place to make sure that you have you have the ability to actually, again, measure out that pro, and the percent free is actually not that hard, but the pro PSA is make sure you get those isomers so you can get that live to patients.
Wow.
Yeah.
Well, that's pretty interesting. Where do you see this heading down the road?
So, it's interesting. It's a new test. And so, like many things, for probably a lot of patients, watching our videos that we have, a lot of patients will say, well, I want that test because it's the new test. I want the latest and greatest. And, with prostate cancer, I always tell people, yes, let's look at this. Let's look at this test and try to figure out is this going to be, is this something we're going to use on everybody, or is this something that we are going to slowly start integrating within the practice? I think it's a very interesting test. I am approaching it very optimistically. Do I think that this is a test that should be used on everybody? And the answer is, I don't know. Not as of yet. I think it's going to be a great test to let us know which patients had a previous negative biopsy, who will potentially help us out. I think people are talking about using this alongside doing MRIs to make sure that we're not seeing, an abnormality there. So it's a newer test. Where I see this going is I see that over the next, 6, 12, 18, 24 months, we're going to get more and more data which tells us that, hey, this is actually could be a very good test for patients that actually have a slightly elevated PSA. And again, right now, the FDA approves this between a PSA between 4 and 10, right? So if you're 11, you don't fit in the category, so you're already a high risk for the most part, so we're already looking at doing something, at least by figuring out a biopsy. If you're below 4, even though the data is certainly encouraging because they actually ran it between a PSA of 2 and 10, shows that, but right now the FDA only approves between 4 and 10. So if you are a patient with a PSA between 4 and 10, we could potentially run this test. But it's being able to interpret that data. Because, like many things in life, I personally don't put all of my eggs into one basket. I like it. I think it's another test that can help us out and give us, again, just like on that spectrum, what is the risk that this patient could be harboring a focus of cancer? I think it's going to play a more active role as the months and years go by.
Is it a characteristic of prostate cancer and the treatment of it that the tests are still, that there are a lot of overlapping tests that you use? It seems like with other conditions it might be a little bit more cut and dry.
Yeah, there are, and that's the challenge. For instance, if you look at, the PCA3 test, which is measuring for, the RNA actually when you're pushing on the prostate. And when it first came out, everybody was raving about it like it was the best thing since sliced bread. And it's not a terrible test, but, I think that test, unfortunately, does have some problems with it. And, what we look at is what's called the area under the curve, which means that how sensitive, for lack of a better term, and what is the likelihood that if this test is positive, we're actually going to get that test and find those patients. So what we're finding now on the early studies on here, and I think they're robust studies, there's no doubt about it, is that this is sort of encompassing a lot of those, which is part of it. But I think what's going to happen is, and as I just sort of mentioned, is that we're going to be looking at these these blood tests, along with imaging tests, and we're going to have to make a decision with all of that together. Again, we had that whole lecture, on MRIs and looking at potentially doing fusion biopsies and things along those lines. We've got to use that, but you can't just put it all in one basket. You can't say, well, MRI is great, well, you're good to go. Your PSA is 20, well, your MRI is negative, oh, you're fine, because again, that continues to just to evolve, as time progresses.
All right, Doc BT, quick question. Can you just give me a basic overview, men's wellness overview? At what age should I be concerned and be addressing this issue about my prostate health with my general practice physician?
Yeah. So, and the problem is that there's so many mixed messages that go out there right now. If you talk to most urologists in the urology community, what we recommend, which is, again, the several international symposiums have actually looked at this as well and recommend this. The Melbourne symposium actually looked at this, and they actually, what I personally recommend is that, a man in his 40s, I think it's a good idea to get a baseline PSA. And why is that important? It's important because, let's say, so Todd, if you come and see me and I get a PSA on you and do a physical, and physical's fine, you're absolute, like a godlike specimen, come from Sparta, right? And the PSA, like, that's right, so, and then what we know is that your PSA, let's make it up, is 0.5. What I can tell you is that the chances of you forming an aggressive type of prostate cancer in the next 15 years is actually very low. Now, that doesn't mean I wait until you're 55, but that's a patient who I can clearly say your PSA is low, your physical exam is low. I'm okay with doing another blood test on you in 2, 3, or 4 years down the road. If you have a significant family history, we may bump up that to every 2 years, and that's sort of where people are looking at it right now. But it's important to get that baseline. And let's flip on the other side. Let's say you've got a family history of prostate cancer. You come in and your PSA is 1.3, right? So, early 40s, for example, average guy, early 40s, PSA is 1.3. Is that a guy that I'm going to say, all right, I'll see you when you're 55? Absolutely not, because those are the patients with a PSA of 1.3. We know that they're at higher risk of developing a prostate cancer in the next 5, 10, 15, 20 years. So we have to follow those guys very, very closely. And you can extrapolate that out according to just that one blood test.
All right, so if I understand this correctly, and guide me when I get off track, because Lord knows I do,
That's right.
Starting sometime in your 40s, you want to get a baseline.
Yep.
And you want to get a baseline PSA, and the person who administers that test is your urologist. Accurate?
No, you can actually get it with your primary care doctor. And I think it's got to be, the challenge is that the primary care docs, unfortunately are getting mixed messages right now. I mean, if you look at the USPTF, United States Prevention Task Force Agency, they basically said they gave, the PSA screening, a D rating, which is basically just garbage. And the problem is that if we go back to where we never used the PSA, we're going to go back to the pre-80s. We're going to start seeing upwards of about 30% of men, coming into clinics with, metastatic disease. We cannot go there. So what you can do is you can request that from your doctor. Say, look, I want a PSA, and say, here's the reason why, and you go from there.
So, Doc BT, it's interesting that you say that because you said the U.S. Preventative Task Force, right? Well,
right.
They're the same ones who came out with the recommendation against mammography. And
right.
Not starting at the age of 40, like we were all, conditioned, but starting at the age of 50. So, that group's got some interesting dynamics that are taking place. And
crazy dynamics. But Todd, let me interrupt you real quick. And I don't know if you remember this, but so this is how men and women think, right? So you got the women who say, you got to be crazy, like you're going to change mammography, and they're up in arms and they're saying, God, you guys are nuts, and this is, and then, like the men, except men that are actually prostate cancer survivors and things like that. So the men, look at it and they go, and everybody's giving high fives and they're like, great, I don't have to get a rectal exam and less PSAs. This is freaking awesome, when they go back to the man cave and eat some more Fritos. So, it's like, this is the way that men and women behave differently. And fortunately, women are still very astute. Certainly men that are married, the women are astute and they're going, man, this just doesn't make a lot of sense. And that's why you've got to watch this thing. I mean, the PSA, a good test, but again, you've got to realize what the parameters are of this test. You've got to use it wisely and make good decisions based on that test.
Well, he's Doc BT, Rich Bevan-Thomas out of USMD in Arlington, Texas. For more information on Rich Bevan-Thomas, you can always go to prostatecancerlive.com. That's the mothership of information. I don't know, we've got hundreds of videos featuring Doc BT and leading colleagues around the country sharing the latest information in the fight against prostate cancer. But you can also go to his website, usmdpcc.com. That's usmdpcc.com. Doc BT, thank you so much for joining us again.
Hey, thank you, Todd. And I just want to throw a quick shout out. We also have a Facebook page that we do. If you just type under USMD, that's USMD stands for medical doctor, so it's USMD. And if you go type under Facebook, USMD Prostate Cancer Center, you can get that. We cover a lot of topics. We try to cover, a lot of the things that sometimes we actually chat with on here. And I just encourage people to join us, and hopefully we can get out more information, just exactly what we do right here.
And for those of you who didn't write it down, I'll make sure tomorrow we get that posted on Facebook and on Google+, the USMD Facebook page. You should be following them also. And as this develops, we've got a bunch of information we'll be bringing right to you here at Prostate Cancer Live. So on behalf of everybody at Prostate Cancer Live and Doc BT and myself, we wish you all a very healthy and happy evening. Best of luck in all of your fight against prostate cancer. And if there's a topic that you would like us to bring up, feel free to submit it in. We'll sort through all of them like we continue to do, and hopefully we'll bring it right here for you at Prostate Cancer Live.